Morning, everyone. I'd like to call to order this March meeting of the Health Plans Benefit and Qualifications Advisory Committee for March. And Marcin, could you make an announcement to begin with?
Yes, Mr. Chair. This meeting is being recorded for this. This is the line for the committee members. This meeting is being recorded for minute-taking purposes, as well as for posting of the recording of the proceedings on the agency's website. This meeting is also being live streamed on the Access Health CT website. It is requested that participants introduce themselves every time they speak. And Mr. Chair, would you like me to do the roll call for attendance?
Roll call now. Yes, that'd be good.
Okay. Graham Rader, Chair.
Here.
Thank you. Sean King.
Here.
Mark Schaefer.
Here.
Matthew Brockman. Manisha Tutani. Tun Goen.
I'm on.
Thank you. John Virkola.
Here.
And Trisha Dave, subject matter expert from Canadian
I'm here.
Insurance Department.
Can you hear me?
Thank you.
Yep.
Yes, we can hear you.
Okay. Welcome, everyone. Okay. Could the senior leadership team, all members, introduce themselves?
I'll start. Hi, everybody. Susan Richby, Director of Legal and Governmental Affairs at Access Health Connecticut.
Yes.
And good morning. This is Rebecca McClear, Director of Technical Operations and Analytics, Access Health CT.
Okay. Is that it so far?
And Kelly Cody,
Kelly, yeah.
Plan Management, Access Health
Alright.
Connecticut.
No public comment?
That's correct, Mr. Chair. We did not receive any public comment.
Okay, so we can move on to approval of last meeting's minutes. Could I have a motion to approve the minutes from a week ago, last meeting?
This is Sean. So moved.
Thank you, Sean. Second? Some
And
other
this
member?
is two, second.
You? Great. Roll call.
Is there
First,
any discussion?
comments or edits or anything like that? Anybody have a? Okay. If not, could we have a roll call?
Okay, yes, Mr.
Approve.
Chair. Graham Rader,
Yes. approved.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman, Tun Goen,
Yes.
Manisha Tutani, and John Virkola.
Yes.
Thank you. Motion passes.
Okay, thank you. Okay, now for the real purpose of the meeting, could we turn this over to Ren Zan from Wakely to show us, more details about the enrollment.
Yeah, and actually, before Ren starts, the next two slides that you're going to see is just a follow-up from our previous meeting. I think a couple members had asked if we could provide some information relating to the breakout of membership by FPL by metal tier. So this slide is demonstrating where the membership is falling under FPLs. So I don't know, we are seeing what we expected to see, the 500 plus. We're seeing that the FPL of 500 or more, or those that are not providing, the NA represents those that may not be providing financial information. We did expect to see that the majority of the membership is enrolling into either a catastrophic plan or a bronze plan. I don't think that was of any surprise, and fewer folks are enrolling in the silver and less are enrolling into the gold plan. But I don't, looking at this slide, I don't see anything that really sticks out.
Is it true that the 400 to 500 actually the state is subsidizing, even though the feds don't? Is that enforced? Is that in play?
Yes, Grant, this is Susan. the temporary premium assistance program, announced by the governor back in December, that is in place for those over 400 to 500 of the FPL. So they are getting half of what their federal enhanced subsidy would have been for 2026. So the ones over 500 and not giving us any financial information are not getting any financial assistance. So it's kind of, as Kelly said, what you would expect. And I think what we were looking at last week too, the highest enrollment in gold selection is in that group.
Yeah, well, that's a catch-all group, actually. Okay, so this shows just where the silvers are very, very dominant and where the bronze kind of rises and becomes far more popular. So, as expected.
This is Mark. I have a question.
Yeah.
Right.
Sure.
So actually two questions. One is, what was the timing of the folks actually not only learning about the governor's announcement, but understanding, getting updated notices that corrected what they would be, how much premium assistance they would be getting? In other words, did a lot of enrollment already happen before that was news to them and could influence their plan participation? The other is, I was kind of hoping there would be a year-over-year comparison so that we could see the change. It's really hard to know, I think, to understand the impact of the loss of premium assistance, and that seems to me this really the central sort of construct I'd like to see.
So I can answer Mark's questions about the temporary premium assistance program, and we can get you right, Kelly. I don't think we have year over year today, but we can certainly get that for the committee. So the information, we had to work with OPM and DSS and the carriers to get this all in place in January. So at the beginning of February, the information did start moving over to the carriers, and Access Health started sending notices to consumers who are getting this assistance with the amounts in there, starting at the beginning of February for those that were already enrolled. To your point, Mark, those that may have enrolled, for coverage starting in January. We also, and the carriers are sending updated premium bills and applying the credits back to whenever the first month of enrollment is. And then we also extended open enrollment till January 31st in the first place. And then after that, we created a special enrollment period, which is still open for consumers that are in those two income bands that are eligible for this additional state assistance. And that's going to run actually for a while to give people time to come in. So during that special enrollment period, someone who hasn't enrolled yet can come in and enroll, but also folks who are already enrolled who are now finding out, to your point, Mark, that they're eligible. If they want to change plans, maybe they want to move to a richer plan, whatever they want to do, that is part of the special enrollment period. They are allowed to change plans. So that is going on right now as we speak. And we put, starting in December and January, and even in December, we put a large amount of information up on our website to get it out there and to brokers so consumers could be aware even before all the data started flowing of, who might be eligible, who might benefit from this, and what they might, be able to estimate what they might be able to receive. And then the notices started running at the beginning of February for those that were already enrolled.
Thank you.
Susan, this is kind of a technical question, just one small detail, but if somebody thinks their income is going to be less than 500 FPL, and it turns out it's not, is there a cap on how much they have to give back?
This is not a tax credit. It is temporary premium assistance. So it's not set up as the same way as the federal tax credits are.
Okay, all right, okay.
The state does have audit rights,
Yeah.
depending if there was, and we are doing verifications of income for all of these folks, but it is not a tax credit the way that the APTCs are.
Okay. Still helpful though, yeah, right.
Okay.
Kelly?
Any other questions on this slide? And we'll definitely get that additional information to you, perhaps by next week. But I think more specifically, this was information that was asked for as well. As we were going over the gold plan, we were talking about wanting to understand from an FPL level who's enrolling in the gold plans. So this demonstrates by FPL the enrollment. Standard plans are broken out from non-standard plans to demonstrate, where the popularity might be or not. So the standard plan has the least amount of enrollment, but about a half of it is coming from those with an FPL of 500 and above, or those that are not reporting financial information. And it's similar across the non-standard plans as well. There's if you're looking at it by bracket, the majority of the enrollment for the gold plan, again, is the individuals with an FPL of 500 or plus.
This is quite interesting. I don't know if we've actually, and not for this month or next month, but eventually we should study what the actual benefits are for these non-standard gold plans that make them so much more. I mean, obviously the premium is a lot lower. That's why they're so attractive. But I kind of wonder how they look compared to our standard plan, and why our standard plan seems to be so much more expensive. I mean,
I totally agree, Grant. I'd be interested in exactly that question, and also whether features of those non-standard plans tell us something, what people are selecting, tell us something about how we should be thinking about the architecture of the plans that we're voting on, in terms of, where you're putting the cost share and not putting the cost share.
Exactly. Yeah. I mean, we don't need to be the most popular plan if the carriers have the right to create these non-standard plans. Certainly, we're creating choice, and that's the important thing. Whether we call it our standard plan or not, it's available, and so are the non-standard plans. But it would be curious just to see why features are popular.
Absolutely. And I think the discussions that we've been having are, somewhat addressing that. I think that with the lower deductible, we're, looking at potentially increasing the plan deductible, perhaps increasing the home health care benefit from a zero copay to, a co-insurance amount. Again, to your point, we don't have to be the most popular plan. And, it is about giving the consumers choices. So I think that's what we're doing. And I think with some of the options that we have out there may get us in get us a little bit more in line, perhaps, with the standard plans, but still giving the consumers choice, because obviously people are enrolling in this plan. They like the benefits. But when you take a look at the cost of the plan, it's pretty significant.
So
oh, sorry, Grant. I was just going to say, to the point that you made, that was something the board, excuse me, decided in the very early days, to allow that kind of carrier innovation and choice, to have standard and non-standard plans.
This idea of co-insurance instead of co-pay apparently creates quite a premium difference as far as the plans are concerned. But I always liked co-pay. I thought it was more definite, just what we're going to be on the hook for. But yeah, co-insurance is definitely something the carriers can price at a more attractive premium. So we'll have to think about that. Okay.
Okay.
Thank you.
You're welcome. I hope that was helpful.
Yeah. Now, Ren, do you want to take us through the new options?
Yes, and today we just want to share a few updates based on last week's discussion. We can skip the first few slides and let's go to plan design. I think the most important updates we came up with the option 2 for gold standard plan, and the highlighted green are the modifications we recommend for option 2 and to make the AV in compliance. So just real quick, we have the deductible of $2,000 and out-of-pocket maximum $8,500, and the co-pays $30 for PCP and special care $60, and urgent care $70. So yeah, we received the testing results from carriers, but unfortunately we didn't have time to update the spreadsheets for their results. But fortunately, seems that both carriers stated their testing results indicate this plan option 2 is in compliance with the AV and also the mental health parity. So any questions on this slide, or we
Any
can?
comments about it? Any preferences?
Yeah.
Well, I'll start by saying I like option 2. That seems to be a nice sort of middle of the road kind of, knowing that we have to improve, we have to do some increases.
Grant, my instinct is the same, and I think my bias is in favor of spreading the increases over all the areas that cost share, which I think as a consumer I wouldn't expect my deductible to more than double. Even if it's a steep jump, it would seem more reasonable to have sort of somewhat proportionate steps on each of the areas of cost share, with some exceptions. Emergency room is already pretty high at $500.
Thank you. Any other comments? Anybody have problems with option 2? Okay. Well, let's move on to the silvers then, but keep that one in mind. All right.
Yeah, the new modification for silver is the option 3. So we changed the out-of-pocket maximum to $11,000, and also the primary care and mental health we changed to $43. So the number is just so the AV it's below 72%.
Interesting. Okay. So.
Yeah, so basically option 3 from the current plan, we increased the deductible by $1,000. And we actually decreased the PCP copay by $2. So make.
Yeah. Here at 6,000. Well.
Yeah, the X-ray and the lab services are pretty sensitive in the AV. So in order to keep the AV lower, so we have to increase these two slightly.
Right. So what we're, I think one is kind of eliminated. That's raising the co-pays on specialist care, and I don't think that's the way we want to go. Or urgent care also. 2 and 3 though are both in play, and it's kind of hard to. There's only a slight difference. One is the out of pocket is only $11,000. Why is? Okay, so everything about option 3 is either the same or the better than option 2. But the premium goes up because the actual value is higher, I guess.
Right, Ren, I don't know if we were able to get any information on the impact on premium for option 2 versus option 3?
Yeah, unfortunately, I think, the
Not yet.
carriers didn't have, yeah, not yet.
Well,
Yeah, didn't have time. Okay.
clearly the premium will be higher on option 3 because it's better. But
Right.
it still
move.
meets the 2% criteria. It's just at the very top of the 2%. And it's subsidized for so many of our enrollees anyways. I would think 3 would be the way to go. In other words, make the deductible 11, or the out-of-pocket maximum 11,000, and the mental health copay $43. Those are the two improved. Yeah, that's probably worthwhile, even if the premium is going to be higher.
I would just know, I don't know that, that's the assumption we've gone on. And obviously this year, the state came in and helped on the premium, but like, I don't know that that's a fair assumption.
Well, what's your assumption?
Go
That that's
forward.
better?
Maybe there's a 2A or something, but I don't know that we should assume that premium is always going to be such, like, obviously it's always going to be, there's an underlying subsidy, but I don't know the extent of that underlying subsidy into perpetuity here. Like,
Oh yeah, no, it's not like they're paying all the difference in the premium, but
right.
yeah. I think we always thought that around 75% of the people got some subsidy, and I mean this is only a 1% increase in the AVA, the actual value, but that could translate to a different increase in the premium. But I guess it's a matter of do we really want to raise the out-of-pocket maximum from 9,400 all the way up to 12,000? That seems like an awfully large increase if we can avoid it. That's what's mostly affecting my preference.
I think I put option 2 there just to demonstrate if we want to keep the primary care and special care copay the same, then we need to increase the deductible and the out-of-pocket just for comparison purposes, like which ones we want to increase, either deductible or the copay.
Right. That's the choice that one has.
Yeah.
Okay. Any other comments? Yeah. Well,
Grant, this is Mark. I guess I do find myself wondering why our only premium increase choice is so substantial. Excuse me, our out-of-pocket primary care specialist urgent care is so substantial, and whether there's a middle ground of $10 increases on primary care specialist and urgent care, and less of an increase on out-of-pocket medical deductible, or both.
So
yeah, we can always come up with different combinations, and if you have any guidance, and I can recalculate and
well, I
see
personally
what
would be interested in seeing a middle ground option where we're between option 1 and the in the current levels for those out-of-pocket costs.
You're talking about instead of raising 45 to 65, maybe raise it to 55.
That's right.
And
Yeah,
on the
unfortunately, I think
specialist
that
care-
the deductible and the move, correct me if I'm wrong, Ren, probably have the most impact in the calculator.
Which one does it? Has the most
The
impact?
deductible, changing the deductible and the move probably have
Yes,
the
yeah,
larger
yeah.
impact on the calculator versus the copays, but I don't know. Ren, is the specialist copay more sensitive than the PCP mental health?
Not necessarily. I think still, if I remember correctly, yeah, they're similar. Probably PCP has more weight than specialty care just because of
specialist,
the
okay.
utilization. Yeah.
Okay,
So I think what Mark is interested in, maybe you could set the numbers, but $55
Yeah.
for primary care, and certainly maybe $75 for specialist care, and $100 for urgent care, and see what that what kind of out of pocket is required along with those kinds of numbers. Can we get it below 11,000 basically?
Yeah.
For out of pocket.
That's right. That's right, Grant. Although I would also allow for some flexibility on the medical deductible to move up to 55 or 57.50. So
Okay.
not ruling that out, and it may be necessary, but whether a combination of more modest adjustments to deductible out of pocket and primary care could get us to where we need a more balanced
Okay.
point.
Okay, so Ren, if you could sort of look at a one and a half, option 1.5, somewhere between 1 and 2 is basically.
Okay.
Yeah, thank you. I know it's you can you can come up with 100 different options here, but
Yeah.
to spread the harm, as it were, every year. Spread the pain from these increases. Okay, let's move on to the different silver plans. Okay.
Yeah, for silver, yeah, 73. Yeah, we came up with the new option 2. So the new changes, yeah, we decreased the outpatient services, copays. And, the new primary care copay is 48. So just a very slight increase.
I also want to note that there is a requirement for the Silver 70 and the Silver 73 plan to have at least 2 points difference. So we need to keep that in mind as we're trying to create the 70 plan and the 73 plan. I just want to remind everybody of that requirement, because that does make it challenging. So if we're going to make changes on the 70 plan, we haven't settled on it yet. This might be the cart before the horse talking about the 73 plan at this point. Unless, of course, there's specific benefits you would like to say and see if it magically works for both carriers.
That 2%, is that 2% on the national AVC, or is it 2% within the carrier?
Within the carrier.
Whoa.
So that's what, that's what that really presents a challenge this year. So
odd. Well, obviously option 2, because it's at 73.9 national, is a more likely successful candidate than option 1, which is only 73.4, because at 73.9, you're already near 2% above the maximum that the 70% plan could be. So the 73% plan has to be at least 2% higher than the 70% plan. Yeah.
Correct.
Wow.
Mhm.
Wrinkles.
and interesting too, sorry, looking at option 1, because that's got not exactly what you talked about, but that's got similar changes for PCP specialist, urgent care, and a little bit, on the lower on the MOOP, but than what we were just talking about for the silver.
Okay.
But maybe if you offset with a higher deductible, that gives you more room on the AV for the
Mhm.
silver.
Well, I
Option
think what we
two.
want to do is, yeah,
Option two as the best potential. So it's a current candidate, right?
absolutely.
Option two. Yeah.
Right. I think the main thing we want to do is have our option for the 73 plan look much like the values for the 70 plan with a slightly different maximums, but keep the copays about the same. I mean, but by reducing the out of pocket and the deductible, or maybe make it a 73. This very interesting out of outpatient services. It's interesting that you could go from 300 down to 100 for the copay. Is that
Okay,
the
it doesn't.
without
Yeah, because it doesn't have a huge impact on AV, so
right,
that's
because
why.
it's actually the deductible. That's why. Yeah. So you have to pay the deductible first, and it's only the people that max out, that reach the deductible that have to.
Yeah.
$100 is a lot better, more attractive than $300, though. But it takes a lot to get to that benefit. So I think what we're going to do here is make whatever option we choose for this 70 plan, we're going to use the same numbers for the 73 plan, except reduce the deductible and out of pocket. Maybe down to 9,600 instead of 10,600 or something like that. So, well, let's move on to the what is it, 87?
Yeah, 87.
Yeah.
Yeah, so yeah, the 87 options are the same as our previous discussion. Any preference? Actually, I think yeah, we only have one option.
Yeah.
Because it's kind of, yeah, they have the least modification needed. So all we need to do is just increase the out-of-pocket maximum slightly. Yeah, so this is the easiest case.
This is the winner, right?
Yeah.
And it's a nice plan. I wish everybody had this particular plan, to be honest. Seems to have, unfortunately, only those with low income can access it. Yeah, thank you. This is I think we can choose this one. This is a winner. So, like you said, it's the easiest. It's the easiest of all of them. Okay, let's move on to 94. Two choices here. Mhm. Any preference about the choice? One kind of is the out of pocket a lot more, and the other one raises the copays. So that's kind of the trade-off between the two. Any comments?
I'd rather leave the copays low.
Okay, but raise the out of pocket up to 2,500.
Yeah.
Well, certainly the fact that they are, this is the really lowest low income, group.
Yeah.
Yeah, copay should stay low. I mean, unfortunately, pay seeking treatment. Unfortunately, they so I'm fine with that. Anybody else have reference? One seems fine to me. I mean, not really fine. I mean, it's sad that we have to do anything, but I'm
And just to
agreeable.
remind, as you were saying, sorry, low income, this eligibility for the 94% plan is up to 150 of the FPL. So
Dozens. Yeah. Okay, I think we can take option one there. We actually do have some ability to choose some plans for voting this time, I think. And then we can sort of concentrate next week on just the silver plans that were more this plan is the one that.
and we still have the bronze, right, Ren?
Oh yeah, we have to move
Yes.
on to the bronze now. Yeah.
Sorry.
Yeah.
Couple of bronzes. Okay, here we go.
The I think I put the option 1 and 2. I think the big difference is for option 1, the specialty care is after deductible. So if we want to specialty care before deductible, the deductible not apply. So we need to make the other changes accordingly. So just that's the purpose. We have two options, just especially option 2. I just want to demonstrate if we want to change the specialty care to be
yes.
before deductible, and then we need to sacrifice some other benefits.
I'm on favor of having specialty care before the deductible, and not need the deductible. I mean, the deductible is $8,000, so you would be restricting the people that actually got the benefit to a very small percentage of the people that sign up for the gold plan. I know the gold plan, I'm sorry, the gold plan, the bronze plan, is basically just to have some kind of coverage in case you have run up a huge medical cost. But it's a plan. I know primary care is covered, but it'd be nice to have something else in the bronze plan that did not require deductible.
I think we've
And-
got some of the drugs, right, Ren?
Yeah.
Some of the
Yes, we have-
tiers of the drugs are before
Yes.
deductible. And also just remember that after HR1, even though we traditionally have called this our non-HSA plan, all the bronze plans are now HSA compatible. So
Okay, great.
consumers have that option as well.
Well, yeah, I like to, other comments or, 2 does raise the out-of-pocket up to 12,000, that's. Okay. It's a lot to take in. Let's see, deductible is not paid. Deductible is not paid. What you said, is there an HSA bronze plan per se anymore, or is that sort of no longer?
Yeah, we still have one in our options, and also just note, as Kelly talked about, I believe this is the plan where we introduced on the home health services, the 25% co-insurance
Co-insurance instead.
after separate $50 deductible.
Well, okay. Is that the next slide? Oh, when you
Yeah,
say
the
this-
height, the
Susan,
yes.
you said that that's the non-HSA, but people with an HSA could actually still.
Right, so
be-
we're, and Kelly and I are talking, we're gonna look at changing these names as well, because, that was always before HR1, how we differentiated the two standard bronze options. The HSA option is really, it's a high deductible health plan. So
Got it.
we may be changing the name to say high deductible health plan. And maybe Kelly, I don't know if you remember, I don't know if CMS has requirements that HSA be in the plan names, for the marketing plan names for all the bronze and catastrophic plans. But we are working on having it either a filter or show up in some way on our website. So and we've got information on the website, obviously, too. So consumers are aware of that. But yeah, so we'll be working on changing those plan names because of those federal changes. So we still do have a high deductible plan option. And I think Ren has it in the next slide.
Any preference on this non-HSA plan today, or still?
So this is the, wait a minute. Okay, we're back to the non-H, did you flip a page there? What does the HSA plan look like? Yeah, we're back
Yeah,
to
for
the
the-
non-HSA.
Yeah, so next slide is the HSA plan. To get the next slide, please. Yeah, so this HSA plan is kind of simple, so we didn't have all these categories listed. Basically, we just have a deductible and the co-insurance.
And okay,
So the
this makes
change
the
is,
out-of-pocket
yeah,
$500 more. It has
yeah, so
the deductibles. The difference between this and the previous slide was $500 more on the out-of-pocket, $500 more on the deductible. Everything's got a co-insurance.
yes.
Everything's after the deductible. Okay. That seems like a winner too. I mean, it doesn't, I only have one option given. So, and it doesn't seem to be a bad one. I mean, it does, unfortunately, increase the deductible.
Yeah, the next slide is the 2 recommendations for leaner bronze plans. So basically, just to have a transition plan for people aged out of catastrophic plan. So we have a high deductible, high out of pocket. So just the 2 options, either 20% coinsurance or 50% coinsurance, which is even would be cheaper. So I don't know the feasibility of this option, or replace one of the HSA or add a new one. I'm not sure.
Yeah, I think that was the what we were trying to talk about. I think at the previous meeting, introducing this third option and potentially putting it out to the group is discussing whether or not you would like to have 3 bronze options that kind of cascade over the range, giving, as Ren said, the opportunity for an individual who may be enrolled in a catastrophic plan, who is still young, feels they're in good health, and that they just need like a catastrophic continuation. This was the option. So this, it could, as Ren said, it could either replace one of the options that we already have, or it could be added to the suite of standard plans.
And the reason, part of the reasoning too, to have this option at the bronze tier is that for consumers between 100 and 400 of the FPL, they can apply APTCs if they're eligible to a bronze plan, but not for a catastrophic plan. So this would give folks an opportunity, who maybe are young, who are not high utilizers, to get help on the premium, but still have some coverage.
Does this make the catastrophic plan design obsolete? Or you still have that available?
No, we still have the catastrophic options, for and now
Yeah,
the feds are changing who can enroll in catastrophic, but catastrophic cannot have APTCs with it. So
unless it was a lot cheaper, then nobody would pick the catastrophic over the lean, would they? Maybe I'm
one
premium.
would hope.
You hope not. Well, I like the 20% more than the 50%, and it's interesting, it's only like 1 or 2%, actual value is only 1 or 2% less. Is there change in price? Yeah. $17 premium change.
I think
Okay.
because when the deductible and the out of pocket so high, it doesn't change as much
Right,
because
but at least
few
after you
people
paid
reach
that
high.
huge
Yeah.
deductible, you're getting a 20%. You only have to pay 20% co-insure instead of 50%. I think 1 is definitely a better choice for the lean bronze if we're going to offer it. Has this been approved by the feds? I mean, this is new to me, so I'm sort of
It would just be a standard bronze plan by us. I
Would
don't
be
know what you
another
mean
standard
approved by
bronze,
the
right?
feds. I mean, it meets, it meets all the federal
It
requirements.
does. Okay, it's just right. We call it lean, but they're just calling
Yeah,
it.
we'd come up with if the committee and the board does decide to go that way, we'll work on a name that makes it clear to consumers, what it is.
Grant, I have a question just about the
Sure.
significance of the $75 versus $92 reduction. What recognizing this depends on the applicant, what's the roughly what are we talking about in terms of the cost of annual of monthly premiums? So the 75.92 is sort of relative to how big of an average monthly number? What's the range?
Yeah, maybe Kelly, do you know that, or does somebody know that? I think it's all over the place because some people on bronze pay nothing now. In fact, they're actually their premium is less than their subsidy. And other people obviously have to pay a lot, even for a bronze plan. So
Right, Grant. So for those who don't have the subsidy and they're looking at, I guess I'm wondering without the subsidy entirely, for those who are looking to cope with maybe they lost the subsidy. How material is 75 versus $92 relative to what they're paying? I just don't have any sense.
Yeah.
well,
Yeah, I think that's we were trying to ask the carriers to provide the premium impact because when I tried to estimate the differences, I can only do it from the claim cost perspective because different carriers, they have different pricing factors and their admin and all the different things involved in the final premium. So in order to have a better estimate of the premium impact, so we've asked the carriers if they can provide premium impact. We haven't received them yet. We can update that with the during the next meeting.
From a high level, it's for the 75, it's roughly 9%. If you move to 92, and this is rough estimates, so don't hold me to
10%.
it.
Okay. Well, one
It's-
more comment.
When you
If you have
when you
no
say
subsidy-
current 2026 plan, is that referring to a current bronze plan?
I think so, yeah.
Yes, the current bronze plan. Yeah, for these two new plans, there is no current plan to compare
Right,
with.
that's why I was
But the
confused on
previous-
that.
Yeah, the previous slides, there is a current 26 plan in the
Yeah.
first column, and the others are options for
I mean,
2027.
I think in some ways it's almost we're looking at it the wrong way. The question is like, am I getting people who would otherwise buy catastrophic or nothing to go into a plan that is a little bit better than catastrophic or nothing, as opposed to so it's the relative to catastrophic is the more interesting question, frankly, as opposed to the relative to bronze in terms of who this is actually intended to target.
Actually, that is a good point. Maybe this is the right time to discuss about the expanded eligibility for the catastrophic plan. So what happened in 2026, there is an expanded definition of eligibility for catastrophic plan, where anyone who do not qualify for subsidies, they would be able to buy the catastrophic plan, which is previously that definition was not there. It was based on a much stricter definition, like 8 up to 25 or 26. And then
That was 30.
right, that's
Sorry, it was up to 8. That one's
so-
age 30.
so now it seems like almost like anybody can buy the plan without subsidies. So the question was, for 2027, do we want to adapt that definition so that we have a lot more people qualified for that? So if that happened, I'm not sure we need this option at all.
Could we look at the?
Well, I
next
think
slide?
this option was for people that would be eligible for subsidy.
That's
To
a
have
good point,
something to
yeah.
apply, something to buy that they could apply a subsidy to.
No, that's a valid point, I think.
Sorry.
Yeah.
Yeah. And the change too is talking about last year when the feds made it last fall. Access Health was one of 4 exchanges that processed their own exemptions. We had the option not to adopt that expanded definition, which we did not, given the timing, the plans, rates, everything. We chose not to do it at that time. But in the, excuse me, in the draft NBPP for 2027, they are proposing, CMS is proposing to make it apply to everybody.
Mhm. Mhm.
So I guess I would, my suggestion is that we should make this catastrophic like almost, but allow folks to get the premium enhanced, right? That's the idea of it.
Right, so it has to be called a bronze, but
Right,
yeah,
yeah, it has to be, but in terms of like,
the benefits.
I don't think we're looking to make it the benefit structure. I don't think it needs to be all that much better.
Does the next slide show the catastrophic plan design? Because, I mean, it's a little hard.
We
to-
don't have a standard catastrophic grant, so we don't, that's not something the committee usually reviews. The catastrophics that are offered are non-standard plans,
Okay, they're non-standard plans, but
but we can look, we can look at the benefit designs and the catastrophics for this year, for 2026, and just compare.
Yeah.
yeah, but one thing I would note is that this $17 difference between the 20% and the 50%, it really mostly is $17 for people that don't get any subsidy, and the people that don't get any subsidy are at least 4, maybe 5 times FPL, which means that they're at least, I mean, FPL is 15,600 now. So if you do it 4 times that, their incomes are over $60,000, and a $17 a month difference might not mean as much for them. Those that are under that income are getting some subsidy, so that $17 difference is not $17 anymore. It's a lesser amount because the subsidy covers some of it. So I mean, yes, we saw that the bronze plans are much more popular for the higher income groups. But since they're higher income, $17 a month isn't quite as impactful to them. I mean, is anybody in favor of the 50% instead? It seems like you're buying insurance, but then it doesn't really cover very much because there's such high co-pays on it, or high co-insurance on it. So that kind of scares me.
Yeah,
hope that
I'm inclined to the 20%, not the 50%, though I am interested in what Matt suggested, which is that we get a sense of how this compares to catastrophic, but if I had to vote now, I'd vote option 1.
Yeah, great. The catastrophic, is that just some kind of out of pocket and then some copay afterwards? What is the design? I know it's non-standard, but what is a common design for a catastrophic? Currently?
Extremely high deductible. I think
Yep.
usually over $10,000 deductible
Right.
for catastrophic plans. Yeah.
And then co-insurance also? Copay?
Yeah. Yeah, I think, yeah, some it's, there's no co-insurance afterwards because the deductible is so high.
So high. Okay.
Yeah, and
So it's more
yeah, I
like an
think some
out-of-pocket.
they do.
Yeah, it's more like an out-of-pocket max. It just says you're going to pay this first before you get anything. Okay.
Yeah.
Well, we're coming up on the hour here. Are there some plans that we might be able to vote for today and get them sort of off the table so that then we can concentrate next week on some I think maybe the gold plan we could vote on today. Is that could I then have a motion to accept was it option 2 that we sort of liked in the gold plan?
Yeah, motion to accept option 2.
Do I have a second? Maybe not.
Dr. Witter, you can also make a second.
Oh, okay.
This is
second that.
Sean. Okay.
Okay. Yeah, I'm just trying to cut down the workload for next week. If we can just get some of the more popular ones out of the way. So roll call.
So, Mr. Chair, did you second or
Yeah.
was it?
No,
Okay.
I think, Sean, did you second?
Sure.
I was going to, so you can mark.
Okay. Okay. Any discussion on the motion before us? Mr. Chair, would you like me to proceed to the roll call vote?
Yes, we can have a roll
Okay.
call then.
In favor of option 2 for the gold plan. Grant Rader,
Yes.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
Tune Goen,
Yes.
Manish Zutani, and John Virkula.
Yes.
Thank you.
Okay, let's skip the silvers. I think we got more work to do on them for next week. And actually, maybe we could, is there one silver plan we could vote on?
I believe it was
I
the
think-
87 and the 94.
Okay.
So can we do those, Kelly, if we're still not sure about the base silver at 70? Does that have an impact with that percentage run or no?
No.
Yeah, I would
I think-
prefer to do silver altogether, just in case there are some other nuances involved if we change the base silver. We can save all the silver and variations and vote them together.
That's fine. Let's look at some of the bronze then, just to end the meeting here. Was there any bronze? Did we have? I forget now. For the non-HSA, did we really decide between the two options? Oh, I like the. Okay, maybe we skipped that one. What about the HSA bronze? Or it was called HSA? Yeah, there was only one option for the HSA bronze. Can we maybe have just to get it off the table, could we choose option 1 for the HSA bronze?
So moved.
Motion.
Yeah,
Second.
great.
Sean.
Sean seconds. Okay, any more discussion? Okay, could we have a roll call on that then?
Grant Rader,
Yes.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
Tune Goen,
Yes.
Manish Zutani, and John Virkula.
Yes.
Thank you.
Thank you. Thank you. Okay. The lien, let's go to the lien plan. I think I heard enough that maybe the 20% was, I mean, since it's all after the deductible anyways. So maybe could I have a motion to accept option 1 on the lean bronze?
So moved, Sean.
Thank you.
Could-
Second?
I would ask that we get the information I asked for before I feel comfortable voting on it.
Okay, we can put that off. Thank you. We'll get that next week then. You were interested in the premiums, right?
Well,
Average
and the
premium.
difference in the benefits between catastrophic and the lean.
Yeah.
How much better this is.
Yep.
than How much?
Just
yeah. Okay,
to-
we can hold off on that. We got 2 voted on. That's a good start. Obviously we have work to do on silver and bronze to maybe look at some in between designs. So yes, Kelly, I'll turn this back over to you. You want to talk about future plans, next steps, that sort of thing?
Yes, thank you. So this will be brief. So obviously our next meeting is scheduled for April 1st. Based on how we are going, do we feel comfortable that we will be able to accomplish our mission by April 1st, or do we believe I need to schedule an additional meeting?
Whoa. And remind us, when is the board meeting, that this all has to be
The 16th, April
Yeah.
16th.
I would suggest we actually put a tentative schedule up for one more meeting after this April 1st
Okay.
one, just in case we don't get done. We're actually making very good progress here, I think. Given the news.
Yes,
Given what
given
we
the
have to
amount of
work with.
changes, we're definitely making good progress.
Okay, so with that in mind, let's put a tentative meeting in there. We can cancel if we get everything done by April 1st. So that would be good.
Okay, we'll get one
Okay.
on the schedule. Thank you.
Thank you. All right. Well, great. Thank you, everyone. Let's can we have a motion to adjourn?
So moved, Sean.
Thank you, Sean. Seconded.
Second,
Any other comments? No. Can I have a roll call?
Crown Ritter,
Yes.
Sean King,
Yes.
Mark Schaefer,
yes.
Matthew Brockman,
Yes.
John Goen,
Yes.
Manisha Jutani, and John Verkla.
Yes.
Thank
Thanks,
you.
everyone. Thanks for all the attention to this.
Thanks, everyone.
Thank you. Bye, everybody.
Thanks, everyone.
Bye now.